Hello, everyone, and welcome to Berman Instruments video series, where we bring you some outstanding talent within our dental community. I'm Lou Berman, the founder of Berman Instruments, and we're in my kitchen in Annapolis, Maryland, where we are cooking up some great recipes for learning more about endodontics from one of my favorite endodontists, the internationally recognized Dr. Bill Nudera. Bill, how are you?
I am doing well today, and I'm thrilled to be on this with you today, Lou.
Oh, thanks. It's not every day that I get to talk to an endodontist, so I'm going to really be bending your ear quite a bit here. Bill, it's amazing. When I went through and looked at your background, it's amazing all the things that you accomplished since you left Aurora, Illinois. Can you give us some basic understanding of what you've done even before you became an endodontist?
Yeah, it all started, I'm a big musician, and I know you are too, Lou, so you can probably relate to this story. And, all my life I've been training as a drummer. And when I was in high school, I was able to get a scholarship to college to play drums for their competitive jazz band. And I thought that that's the track that I was going to do. I thought I was going to be a professional musician. And it just turns out that that just wasn't in the stars for me. So in college, I got really heavily involved with math and science and biology, and I started gravitating towards that particular aspect of education. And on one holiday home from school, I have an older brother and I have a younger brother too, but my older brother was considering the healthcare profession. And my father, who's a dentist, took us to a tour of the University of Illinois at Chicago Dental School, just to kind of give us a look around. And I immediately fell in love with what I was seeing. And at that point in time, my path was solidified. So although I had contemplated at one time actually dropping out of college and pursuing a career in music, it kind of took a 180 for me. And I just focused everything I could on completing some prerequisites and getting everything I needed to go to dental school, because that's what I really wanted to do. And spent 4 years at University of Illinois, Chicago, learning dentistry. And when I graduated, I wasn't quite as confident with my skills as what I was hoping to be. I had a great experience, had a great education, but I didn't have enough domain knowledge to really feel good about going out and practicing in the public arena. So one very important aspect for me was to just gain experience through continuing education. So I pursued an education through an advanced education in general dentistry residency program through the Air Force, and practiced general dentistry for several years before going back and then applying to my endodontic program. And so that's, in summary, a brief history of how I became an endodontist, is just through the route of experience and learning where I needed to gain some more experience and just falling in love with endodontics. Because when I left dental school, I really only did 7 root canal treatments, and they were all by hand. Now, you got to remember, I graduated, in 99. And Lou, that may have been just a little bit after your graduation. But remember, engine-driven instrumentation only came out in 95. And I started clinical practice as a student in 97. So we were still being taught the old school hand filing techniques of balanced force and serial step back. So I left school really not understanding what engine-driven endodontics was all about. So I had to then learn it on my own after school.
Well, it's a hard path. It's interesting that you had that music background also. I think that I was leaning in that direction, but I thought, I could be really, really happy being a musician for the rest of my life, but am I willing to live a life of poverty? And I wasn't willing to do that. So the endodontic route was a really good one for me also. But it's really great that you had all that general practice experience before you became an endodontist, which I never had. How did you think that benefited you when you became an endodontist?
Well, I think it was invaluable, because I spent 4 years just understanding restorative dentistry. Now, it takes a lifetime really to understand restorative dentistry. So I'm not trying to condense it, like I learned everything in 4 years, but what it did, it helped me understand restorability and what I needed to do, communication between the general practitioner and the specialist. So by the time I actually finished my endodontic program, I not only had some experience now as an endodontist in root canal treatments, but I had that experience of communication, of how to bridge that gap and knowing how to make the communication seamless between the specialist and the general dentist. And also it helps me have a seat at the table when it comes to treatment planning, because the biggest factor of success long-term is understanding the teeth that have the best chance at long-term survival. And that's what we really need to understand is endodontics has a wonderful success rate, but it really depends on a lot of pre-existing conditions that have to be taken in consideration. One specifically being the actual structure of the tooth and what we have left to work with. And having that general dental experience and understanding what can and can't be done really helps me help my community and my referring dentist understand what I feel is possible from not just the endodontic standpoint, but from the restorative aspect as well.
And do you find that that's a pretty constant conversation that you have with your referring dentist?
It's not just a constant conversation anymore. I am getting called just to help people treatment plan, which I love that. I mean, that's what we do. Endodontics, the actual physical root canal treatment of what we do, even though that's the procedure that our specialty is known for, is just a fraction of what endodontics is really all about. Endodontics is about bone, support, foundations, predictability, probability. So when we're treatment planning full mouth rehabs or even a single tooth restoration, before we start anything, we're on the phone. We're helping treatment plan the actual final restoration and the likelihood of long-term success. And not only do I have that conversation quite frequently with my referring dentists, the patients involved with the conversation.
Sure.
I love doing heroic dentistry. And a lot of times we're seeing a lot of heroic things here. I don't mind taking risks and trying to save teeth that are more compromised, as long as that patient understands those risks and is on board to take those risks with us. And that's kind of how we look at this.
You know, that's a great way to approach it, because again, it's just a small part of what we do is, you know, the cleaning and shaping and obturation. I think diagnosis and especially prognosis assessment, huge. It's a really big part of what we do. And it's great that you feel comfortable with and have the background to be able to communicate that to your referring body. I mean, it's pretty much everything. Because of the overall way that you're approaching this as an endodontist, looking at it from a general dentist point of view, how do you think that really affects your overall outcome? I mean, it's got to really overall improve your endodontic success, not to mention the restorative success.
Yeah, well, I think it's had a tremendous impact, because we've established ourselves in our community, not just as endodontists, but we also offer that restorative component to our treatment. We are restoring the vast majority of our cases when we're done with the endo with our buildups. We're putting posts in, we're putting cores in, almost every tooth we treat. Now, if our referring dentist wants to do something different with the final restoration and does not want us to put in the core of the post, we're okay with that too. But we're always doing some sort of bonded orifice barrier. We've got to protect our work. One of the biggest variables for long-term success is what's that patient going to do when they leave our office before they go back to get that tooth restored, and how long is it going to be before that happens? So we are what we call endorestos. We do endodontics and we do our restorations. And in some cases, we'll get referrals from our referring dentists that say they want the endo done, they want the post and core done, and they want me to prep the margin for the crown. I'm happy to do it. I really am, because I have that experience because of what I was able to do before I went down to endodontics or went up to endodontics.
Do you think that's unusual? I mean, is that the exception to the rule? Because I think it's more geographic. I see that some endodontists do what you do. I don't. And I think the service that you provide is outstanding, because again, the reason why a lot of these cases don't heal up long term is because of coronal leakage or just the restoration breaks down. I think it's excellent that you're doing that, but I don't see that nationwide unless you are seeing something I'm not.
No, I'm not. It's philosophy, Lou, and it's not nationwide. And I think very few endodontists, if we actually were to survey them, and I'm guessing, but I would think that most of them are not doing a lot of cores and buildups. It does take more time to do, so we do have to schedule more time for that. But it was just really important for me when I was developing and growing my practice, just to do something different than the endodontist that was across the street. Now, I opened in the Chicagoland area. We are saturated here with endodontists. We opened our practice right almost across the street from the endodontist that was there for 30 years. And in order to make ourselves known, was we were unknown in the area. We have to do something different. So we started offering services that the other endodontic clinic wasn't offering, like post, cores, and buildups. And at first, the community was a little bit off-put by us moving in that direction, because the thought was stay in your lane, stay in your lane. That's not your job, that's our job. But we also were going to these dental clinics, doing lunch and learns, helping them understand the value of applying these final restorations, posts and cores under rubber dam isolation. And that is where we actually began blooming and building and growing our practice, because once we can help the general dentist understand why we're doing it, then they were more apt to allow us to do it. Now, I've got to be clear, not everybody wants us to do that, but our top 10 referring dentists that refer to us, they expect it.
That's interesting. You know, Bill, it's no big secret. I've seen you lecture so many times. You're outstanding. You write the screenplay and you act the part and you put it all together. I mean, you're a fabulous presenter. And I know you do a lot of teaching to general dentists. How has that affected your endodontic practice?
Well, that's a really great point too, because again, I'm going to go back to when we were growing our practice. I say we because I practice with a partner. We've been together for 16 years. We've known each other for 25 years. We have a really similar, I mean, it's exactly the same philosophy. So when we were building our practice, again, the most difficult thing about building any practice, be it a general practice or a specialty practice, is building a reputation. The difference between a specialty practice and a general dental practice is we're not marketing to the average person. We're marketing to the general dentist. So one of the ways that we would go and try to get our name out in the community is we would go and offer to teach our local general dentists on how to do endodontics. 90% of the dentists that were referring to us when we first opened within our first 5 years were performing their own root canal treatments. And I'm all for that, because as a general dentist myself for 4 years, I was treating 90% of the cases that were coming to me for endodontics because I felt comfortable doing it. And it'd be hypocritical for me to say that the general dentist shouldn't be doing endo. I think they should be doing endo, because the fact there's so many cases out there that need treatment, there's just not enough endodontists out there to do it. So it's our job in our community to train our referring doctors on how to do it well. And we would preface it by, hey, we would support you moving in this direction. We're supporting the general dentist in endodontics. But if you run into a problem, hey, we're right here. Send them on over. We'll help you. And when we started educating our general dentists on how to do endo better, they began to realize the cases they probably shouldn't start as opposed to the ones that were within their scope of practice. So over time, our practice just grew because we tried to teach them how to do endodontics. And you think that'd be counterintuitive, but it worked like a charm.
You know, that's really makes a lot of sense. And it's a great way to grow your practice as an endodontist. You know, when I look at all the different things that we've gone through as endodontists in the past, rotary driven instrumentation, surgical microscopes, it seems like most of the endodontists now have cone beam in their office, CBCT. How has that affected your practice, your patient outcome, and your relationship with your referring dentist?
So cone beam has been around, or at least introduced into endodontics back in around 2008, 2009 is when I started hearing about it. We kind of did some deep diving into it over the first couple of years, kind of seeing what some of our other colleagues were doing in that realm, in that space. And my partner and I decided in 2011 that we've got to jump into this. This is just a fantastic piece of equipment that we can't deny. And like all other endodontists, when we first started getting involved with it, we're like, okay, we're going to limit our scans to retreatments or those cases that just look a little strange on our PAs. And it only took us 1 month scanning people to understand that, hey, we need this on every single case. So now for 10 years, we have been scanning 100% of our endodontic diagnostic cases and our endodontic treatment cases. There is so much information that is available on that cone beam scanner. It's a game changer. There are two pieces of equipment that influence the quality and the successful outcome of any endodontic procedure. That's magnification, which is our dental operating microscope, and the cone beam scan. Now, if you had to take one of those away from me, I would gladly give you my microscope before I give you my cone beam scan. That's how important that scan is for me in order to move forward with the treatment. Now, fortunately, I don't have to give up any of it. I get them both. But what I'm trying to portray here is the value that three-dimensional imaging has on our treatment outcomes, our predictability, and our visibility and efficiency during treatment, because we have our lengths, we know how many canals there are, we know where we're going, we can direct our access. It is a wonderful piece of equipment, and it's not going anywhere. So anybody listening to this who has a scanner and is not using it for endo, you should consider starting to understand how to do what I call endodontic overreads. I'm not a radiologist. I don't do full overreads on my scans. I do what I call endodontic overreads. I read the anatomy of the tooth. So that's important to understand too. And after taking thousands and thousands and thousands of scans over decades, you start understanding more of what the two-dimensional images look like and can start predicting what that three-dimensional scan will look like as well. So it is something that I can't practice without anymore.
You know, I hear you, and I'm there with you 100%. There's nothing like having a roadmap before you take a trip, and it tells you, where the unusual anatomy is and just why maybe you might have problems with a particular case or not. It's just absolutely invaluable. But again, that's the nuts and bolts of what we do clinically. I agree with you in your original assessment that a big part of what we do is diagnostics and prognosis assessment. And I don't mean to embarrass you, but I got a copy of your book here, and this is unbelievable. When is this coming out, Bill?
So it just launched. It's about a week ago. And what this book is, it's a new way to approach diagnosis and case selection. And what I recognize, and you're a teacher too, Lou, and I've always followed what you've done, and you've done some remarkable things in our specialty. And I've always looked up to that educational background that you've been able to afford me. I mean, I read your book that you're the executive editor on, Pathways of the Pulp, and that's pretty much our clinical guidebook, basically, for the information that is all of endodontics. But after teaching for 10 years, residents at the postgraduate level and general dentists alike, there's a gap in our educational model, because we've got all of this wonderful raw data. It's wonderfully organized in textbooks, literature, case report. But the problem is translating that raw data into its clinical application and what it means for your patient at that point in time with that particular problem and that particular scenario. And what I've done with this book is I've pretty much given a playbook or the framework for how to walk through the process of endodontics, not actually doing the procedure, but the thought process of how we come to conclusions based on probability and certain aspects of the radiographs and clinical exam that will help guide us to making better decisions. So the goal of when we read this book is not to teach the volumes of information that are within the book, it's to teach how to use the algorithmic system that was created. Because if we can understand the actual map and what it means, then we don't have to sit and learn all that domain knowledge, because the domain knowledge is in the book. So if we understand how to use the book, we now have a tool to help us guide through decision makings as if you were sitting in the mind of an endodontist.
That's a great way to put it. I was actually taken back because I've never seen a book like this. I mean, you're in the field, you've never seen it. It's the thought processes that are going on. I tend to think in bullet points, and I actually think in organizational charts. If this, then that. And I've never seen that in a book before. I've never seen it articulated that way. So each section of the book, and it's pretty much all about diagnostics and case selection. Would you say that's pretty fair?
It's diagnosis, prognosis, and case selection. That's it.
And it's a big deal, and it creates, an image in your mind of what the thought processes are when we look at a case and try to assess that. So the organizational charts that are in there are very graphic, very easy to read and go through. On top of that, as you give different descriptions in there, you have beautiful photography in there, and I was so happy for you because a lot of times you put together images like that with beautiful color correction, and then it goes to the printer and it looks like crap afterwards. But yours looks great. You did a great job, and your printer obviously did a really great job also. So I'm proud of you for putting that on and being able to give us a resource where we can think like an endodontist and try to go through the thought patterns that we have. And it's an easy book to go through. So what made you do this? I mean, it's a great idea.
Lou, I think this has potential to be a game changer for how we teach our specialty. This was written so that all you need is a third-year dental school education. And then you've got all the domain knowledge that I could come up with and how to interpret that literature, all at your fingertips. And it's a way that we could share that domain knowledge and fill in those gaps. And so what I recognize, specifically teaching at the University of Illinois at Chicago, residents specifically, is when they're in the clinic, I'm staffing, I'm the attending, and when they run into a problem, what do? Well, they get up from their patient, and they come and grab them, and they go, Dr. Nudera, what do I do next? What's my next move? And realistically, when we break it down to its most simplest form, there are really only 2 or 3 choices we have for any given set of scenario information that's available. So if we can just break it down and outline every single option we have based on that particular situation, then we go in a pathway that helps us answer the question of what do I do next? And once you make that choice, there are more choices to make. So when we can sit and map out every little aspect of every option or choice or decision we have to make down to its finite components, then when we can organize it systematically, then that thought process and decision-making process actually becomes quite simple. And everybody thinks that endodontics is so complex and so complicated. And really the beauty of endodontics, diagnosis, prognosis, and case selection lies within its simplicity. And I'm not saying endo's easy. I'm saying it can be simplified to the point where anybody can understand it.
Well, from the background of an incredibly great endodontist, with the foreground of having such great clinical skills as a general dentist, a captain in the Air Force, and doing the general dentistry, it's great to have somebody like you putting this all together. And it kind of goes with our theme for Berman Instruments, where dentists are helping dentists. We're so appreciative to have Dr. Bill Nudera with us today. When our endodontic community talks about the outstanding endodontists in our field, Bill, your name is always front and center. Thanks for your tremendous insight today and into the world of endodontics. And most important for right now, how do we get your book?
Well, the book is available through Edra Publishing, or you can get it on Amazon. And I really am looking forward to seeing what potential this concept has. It's a new concept. Again, I didn't come up with the information in there isn't novel. All I've done was just assembled it in a way that people can interpret and understand it. So yeah, look it up on Amazon. You can go to edrapublishing.com and buy it there. And Lou, I'm going to add too of what you're doing for the dental community with your company, Berman Instruments. What you've been able to do by decreasing our overhead, because I use your company all the time for anything I can buy. I'm going to Berman Instruments. And my favorite thing that I like to order from you is the DG1617 Endo Explorer. It's so inexpensive. It's almost less than the cost of an engine-driven instrument. And what I've heard on a lot of social media sites is, they get frustrated with the Endo Explorer because it always blunts, it always bends, and they're a little timid using it because they don't want to have to spend, $20, $25, whatever the cost of these premium companies are charging for these DG1617s. But now when you can get it for almost pennies on the dollar, it's basically disposable. And now we can get to use it properly without worrying about spending a lot of money to have to get another one. So that I use a lot of your rubber dam retainers, but this DG1617, that's my go-to. So I want to actually express my gratitude to you for coming up with such a wonderful concept to help the end user like me benefit as well.
Thanks, Bill. That's what happens when dentists vet the dental products and provide them at an incredibly great cost. Um, it's nice to have you plug that. I wasn't asking you to do that, but it's great to hear, and we're glad to help everybody out. And thanks for you helping us out today. I'm Lou Berman, and thanks for joining us today. Please check out our website at bermaninstruments.com for more conversations with some of the most outstanding leaders that dentistry has to offer. Thank you so much.